staff from the Appropriations Committee, what we recognized is that there is an issue with funding, no question, but how exactly funding should be allocated to the states for these programs and what will be the best use of those dollars is very much an open question. And so based on the advice that we received with folks who are far better experts than we are in this space, we met with the appropriations committees, and on the House side, they included in the House committee passed labor HHS report language that I believe is on the screen for those of you all who are on the webinar. This language that basically requires the next administration, when they submit a budget request, to actually outline what steps the administration believes need to be taken in order to encourage all states to implement REST recommendations within a year of their addition. I mean, obviously not all states can do it within a year, but I think the point of this report is to figure out what would it take to have it be something that could be implemented that quickly. And then based on that, I'm hopeful that as we have this language, have some more data, and hopefully this language will need to actually continue forward through the appropriations process that they're winding down at the end of this year. And if it's adopted this Congress, that language could then push the next administration to submit this report. And with that report and that new data, that data would be useful for those of you all who are working on this in the reauthorization of the newborn screening program and potential additional changes that need to be made there. So with that, I think I gave the big 50,000-foot overview, but I'm happy to answer any questions people may have about the language and where it stands in the process.
Great, thank you, Cheryl. I will now open up.
A lot easier than trying to boil the ocean and see what we find. I'd rather, go with the sponsor.
All right, does anyone have any questions for Cheryl?
Actually, I do have a question for Cheryl. You mentioned that language passed by the House Appropriations Committee, is that right?
That's correct, yes.
So what's kind of the next step for it to become adopted?
Sure. Well, it depends on how post the election, when Congress comes in from lame duck, whether or not they are going to do one large omnibus package or smaller bills, which they're calling mini buses, or if they decide to do a continuing resolution. So the language in these committee reports would need to be conferenced between the House and the Senate body. Now, we've made the Senate folks aware of the language because we've had very positive meetings with them over there, with the Senate folks, and I think they recognize the concerns being raised not only at the state level about the screening programs, but also are interested in having more data about what actually could be done and where best uses of dollars could go. So I'm hopeful that this can be included in a final end-of-year package, but as we all know, the end of year is a little bit anyone's a guess right now.
Great, thank you. Does anyone else have any questions for Cheryl? Okay, with that, I will close the lines back up. And if anyone has any questions throughout, you can feel free to use the chat or the Q&A function to ask any questions you may have of any of the panelists. So with that, I'll move it over to Stephanie Silverman, who will give an update on the 340B drug pricing program.
Thanks very much. I appreciate the opportunity to be with you all. We run an organization called AIR 340B at Venn, and so I'm speaking in my capacity as a spokesperson and the manager for AIR 340B, which, for those of you who don't know, the entity is a stakeholder alliance that brings together the interests of patients and clinical specialty groups, public health advocacy organizations, and innovator companies to focus on policy challenges and opportunities regarding the 340B drug discount program. I was asked to give a little overview on the 340B program itself, so I'll try and do that briefly. I'm happy to take questions offline, and I really don't want to reiterate information that many of you may already be familiar with. So if you know this background, forgive me, I'll try and be brief and focused here. The 340B program was created in the aftermath of 1990 Medicaid drug rebate policy changes. The goal at the time was to ensure that patients in need, and in those days, uninsured, at-risk, economically disadvantaged patients would have access to hospital outpatient drugs, which can be expensive, especially in the absence of insurance. And the drug discount program was created as a specific standalone statute to allow for two different kinds of entities to get discounts on drugs that they purchased that would be used in a hospital outpatient setting, or through certain what we call covered entities, which are the public health focused, Ryan White clinics, community health centers, hemophilia clinics, and the likes. Again, the goal was to ensure that there were discounts provided to the entities that would affect a benefit to the patients. Over time, what we've seen and what so many stakeholders are concerned about is that the program itself, the 340B discount program, has grown from an original participant group of about 51 hospitals, and now I'm just focusing on the hospital participants because that's where I think many of the concerns are focused right now, to about 40% of all U.S. Hospitals today that participate in the 340B program. There are a lot of reasons for hospitals getting into the program, but the most significant of them is that there's an opportunity to arbitrage dollars between the discounts that they receive from drug companies and the prices that they pay, which I think makes the point that's important to this community, and that is that patients are not given direct access to the economic benefits of the 340B program while increasing numbers of funds. Many billions of dollars have gone to participating hospitals over the last few years. I think notably in 2015 we saw that about $12 billion in discounted value of drugs sold through 340B to 340B hospitals, and that's about 5x what the number had been 10 years prior. And the vast majority of those 340B sales, as I noted, are through 340B hospitals. The reason that we're talking about 340B today is not because we wanted to apprise you of the program itself, but of new efforts to expand 340B with reference to orphan drug prices, and that I think is where the RDLA community may have some concerns and some interest. As you'll see on the next slide, there is an active effort underway by AIR 340B members to promote thoughtful guardrails around the 340B program with the sole intent of ensuring that the benefits of the 340B program redound to the intended beneficiary community, and that would be to uninsured, underinsured, or otherwise economically disadvantaged patients who are intended to get the 340B benefits in the first place. The consequences of the rapid expansion of the 340B program have been not only detrimental in terms of strict economic issues, but also because as hospitals have looked for ways to increase their 340B revenue streams, they have increasingly gone out and acquired other standalone independent practices that could generate more 340B spending and arbitrage opportunities for themselves. And so what we've seen, for example, is an active path to acquisition for growing numbers of independent community oncology practices, among others, taking those oncology practices out of communities, often rural communities, and bringing them into the hospitals and affecting not only, difficulties for patients who have to access those new facilities, but also significantly, as we've seen in a number of third-party studies, growing the cost of access to cancer treatments, among other things, because the treatments that are provided in the hospital setting have been substantially more costly to patients and to payers than they were and continue to be in existing community oncology infrastructures. So that's among the concerns that are out there. The AIR 340B community has been pressing Congress and regulators for changes to eligibility criteria for the hospitals, changes to make sure that patients are directly beneficiaries of the program, and other rules that limit appropriately the sharing of revenue streams without reference to patient communities with large retail pharmacies who are now also getting in on the 340B arbitrage opportunities, and increasingly growth of contract pharmacy arrangements connected to 340B hospitals have been outside of areas where you would normally find patients in need. Of late, there have been concerns that are specific to the rare disease community with the introduction of a piece of legislation called HR 6174, which is intended to now extend 340B drug benefits for orphan drugs provided in a hospital outpatient settings for indications beyond the original rare disease indication. So off-label utilization or, secondary or follow-on indications that extend beyond the original indication of those drugs. There was an exemption that was created in the Affordable Care Act that was designed specifically to ensure that orphan drugs were not included in the universe of drugs subject to 340B discounts. There had been litigation to preserve that exemption that was successful. So this new piece of legislation, which we expect to see reemerge next year and have a lot of momentum behind it from the hospital community in particular, would subject drugs, new drugs or existing orphan drugs that are provided in a hospital outpatient setting to the discounts that other drugs are already being subjected to. The concern about the discounting of these drugs is mostly about what disincentives it would create for new innovation in the rare drug community. As you all know, about 50% or more of orphan drug new molecular entities approved between 1983 and 2014 were first-in-class treatments, but there is a lot of work that is obviously being done in orphan drug innovation, a lot of work that you all are talking about in the context of cures and elsewhere to promote new advances in rare disease therapies. The concern here is that the economic adverse impact to innovation from shifting funds principally to 340B hospitals and also to contract pharmacies and away from the innovator environment might create an aligned disincentive for next generation innovations. So the goal, I think, both among the patient communities that we work with and the innovator communities and the public health organizations is to push back against this proposed new piece of legislation to ensure that there continue to be adequate incentives for the development of new treatments for orphan diseases. There are also problems with the measure as proposed because it puts a lot of new burdensome reporting requirements on those who really shouldn't have it, and that would be the so-called covered entity community. That's the smaller public health organizations that have a lot more burden of serving patients in need and would have to do a lot more documenting of how they provide which drugs to which patients and which patients in those communities and community health centers present with what kind of diseases. So we also don't want to see any kind of new administrative challenges for that community of providers who are doing very, very important work. So the 340B conversation will continue. There's been an effort this year to advance what's called mega guidance out of HRSA. It does not look like that mega guidance will get out of the Office of Management and Budget this year. We expect that the issue is probably going to peter away with the end of the current administration and maybe resurface next year or after. The hope by the AIR 340B membership is to see real efforts in the regulatory environment to put checks on the existing program so that the benefits continue to redound to patients or redound anew to patients, and that the economic interests that are being served outside of the patient communities are more carefully scrutinized. So I think that's our update. I'm happy to answer specific questions either on this call or offline, whatever would be easiest.
Sure. Thank you, Stephanie. I will open up the lines now for anyone that has any questions regarding 340B. So the lines are now open.
Hi, it's Michelle Oshman from Lilly. Thanks so much, Stephanie. I think it's a fantastic update, and I think the key takeaway from a patient advocacy perspective very much aligns with Stephanie's presentation, and that is that unfortunately the small entities, right, the Ryan White clinics or others, currently have quite a significant reporting burden that seems to be disproportionately sort of face, an onus on those organizations, and those are the ones that truly need the 340B program, and also within the hospital framework. Unfortunately, a patient who is not insured may in fact be charged full retail price from the administering hospital rather than the discounted price that it was procured at. And regardless how that is broken up, I think that because the patient at the end of the day who is receiving their treatment through a hospital is not seeing that significant discount, or we really do have serious concerns about further impacting a community that is already significantly economically disadvantaged.
Great, thank you, Michelle, for the deeper explanation. Does anyone else have any questions for either Stephanie or Michelle? Okay, well, thank you, and I'll move it on to Paul Melmeyer with NORD, who will give a short update on the Priority Review Voucher Program.
Thanks, Vignesh. This is Paul. Good afternoon to everyone on the East Coast. Good morning to all of you on the West Coast. Just a quick update on the Rare Pediatric Disease Priority Review Voucher Reauthorization. I'll be brief because I know I'm a last-minute addition to the agenda. I know many of you are very familiar with this program. This is something that many of us within the rare disease patient advocacy community have been working on very hard over the last couple of years to get this program reauthorized for a long period of time, as well as to improve the program, make a couple policy changes to the program. So before I get into the latest news on the reauthorization of the program, first I'll just give a quick background. This Rare Pediatric Disease PRV program awards a company a priority review voucher if they first develop a therapy for a rare pediatric disease. Now, that voucher can be used for any other drug that can get a priority review for that drug, a drug that would not have otherwise qualified for a priority review, and that voucher can also be sold if that specific company that earns a voucher doesn't want to or doesn't have to use it on one of their other therapies. These vouchers have proven to be very, very valuable. The latest one sold for about $350 million, for example, so obviously a very large economic benefit associated with these vouchers. So we believe that these vouchers are indeed very effective in encouraging development into a very neglected area in rare pediatric diseases. And so because of this, we've been very supportive of reauthorizing the program. This is a program that was passed in 2012 that has awarded 7 vouchers since its passage and is currently set to expire at the end of this year, December 31st. Now, we have succeeded in getting some short-term reauthorizations over the past year or so, the latest coming actually at the end of September. Just a few weeks ago, we were successful in passing the Advancing Hope Act. Now, the Advancing Hope Act only extended the program for 3 months, kind of bought us some more time to get a longer-term reauthorization, but it also included some very important policy changes to the program, including redefining what a rare pediatric disease is in order to make it a more appropriate definition, I suppose, for this specific program. And some other important provisions as well were passed. So since we only have until December 31st to get this reauthorized even further, we are really hoping for a concerted push from the rare pediatric disease or just rare disease community in general. And our opportunity to do this is through passing the entire 21st Century Cures Act. Rare pediatric disease PRV reauthorization has been included in both the Senate and the House versions of 21st Century Cures, and we understand that through 21st Century Cures, the main proponents for this program will again try to reauthorize the program for a longer amount of time, hopefully permanently, but if not permanently, perhaps 10 years or so in order to really incentivize development now into rare pediatric diseases. So I wanted to let everyone know that we will be circulating a sign-on letter within the next week or so, hoping that any and all patient organizations that want to sign on to that sign-on letter will indeed sign on. And also we'll be circulating other advocacy opportunities to send letters to senators or representatives, opportunities to give their representatives, congressmen, senators, whomever a call to support this program. And again, we're hoping this will be passed as part of 21st Century Cures. There's obviously a lot of really amazing things with 21st Century Cures. I'm not going to get into that any further because I know Max will be talking about that at the end of the call, but I wanted everyone to be aware that we will be circulating that letter. And if you are not signed up for our email alerts, we'll also be talking about it on Twitter. Our handle is @RareDiseases, as well as on Facebook. So follow us on one of those two there. You'll find the opportunity to sign on to the letter if you so choose, and would be very thankful for your support. Thanks.
Thank you, Paul. Do you have a moment for me to open up the lines for some questions?
Absolutely.
Great. I will do that right now. So any of you who have questions for Paul can feel free to ask them now. Okay, well, hearing nothing, I will let you go, Paul. But thank you for your update on the Priority Review Voucher Program.
Thank you for having me.
Great. With that, I'll give an update, relatively short, on the Foundation's work on newborn screening and our plans for the coming year. So to give some background on our newborn screening efforts, the impetus for working on this legislation was that each state has its own newborn screening panel, and there isn't very much uniformity between states. While some states screen for as few as 29 diseases, other states screen for nearly 60, and as a result, many babies fall through the cracks of this patchwork of laws. And additionally, there is a federal panel that issues a recommended uniform screening panel, and that recommendation, unfortunately, isn't binding on the state. So it can take up to 8 years before a state actually begins screening for a disease that's recommended by this panel. And during this time, patients and parent advocates who decide to push legislation on this, they have to testify in front of each legislature while their children get sicker. And you know, as a result, we have incredibly harmful health outcomes. So the Foundation introduced a piece of legislation that was authored by Senator Richard Pan here in California. He's a pediatrician. And this bill allows the state to screen for a disease within 2 years of recommendation by this advisory committee. It eliminates any additional legislative delay in screening and allows for the earliest treatment possible, which can lead to saving many lives. Patients additionally can now work on adding diseases to the RUSP instead of having to go to every state legislature for each one of their individual diseases. This bill was signed into law just a little bit over a month ago on September 16th, and had over 120 patient organizations showing support. As a result, California will have to screen for MPS I and Pompe by August 26, 2018, and then the state will have 2 years from the addition of any other disease to the RUSP to start screening for those diseases as well. So in terms of what we're looking at doing next, we would like to, first note that California was the first state. We'd like to introduce similar efforts in states with high birth rates so that those states will, at a minimum, screen for what's on the RUSP. As part of that, we'll have a state newborn screening RUSP realignment toolkit that other organizations and, patients are able to advocate for their legislatures to introduce similar legislation. Additionally, the Newborn Screening Saves Lives Act is up for reauthorization in 2018. We'll be hosting a How to Add Your Disease to the RUSP webinar coming up. And additionally, we're looking to do an economic study on the cost-benefit of expanding newborn screening. So for the toolkit, this toolkit will include a step-by-step guide on how to pass similar legislation in other states. Of course, this will give some background onto how state legislative processes work, what to look for when trying to find a sponsor, how to build a coalition, and other resources that a patient organization will need in order to pass similar legislation. We're hoping as time goes on, we develop more experience and a network of individuals that can act as resources for each other to move similar legislation. Additionally, the Newborn Screening Saves Lives Act is going to be reauthorized in 2018. This law was passed in 2008, and it includes a number of grant programs for newborn screening, some informational outreach, and it lastly created the advisory committee that makes recommendations for what diseases are screened on the RUSP. This bill was reauthorized in 2014, and it's set to expire, so we're hoping that we're looking to make sure that a robust version is reauthorized in 2018. Additionally, we'll be presenting on how to add your disease to the RUSP webinar. This webinar will train advocates on how to nominate a disease for addition to the RUSP. It'll provide some background on what the committee looks for in making its determination. This includes, what treatments are available, the cost of screening, the prevalence information, and all of that. Hopefully that can give some guidance to patient organizations that would like their disease to be screened for. And additionally, allow advocates to share ideas and work together to ensure that rare diseases can be screened for early and effectively. And finally, we've mentioned this on prior webinars, but I'd definitely like to highlight that, we're still looking at doing an economic study on the cost-benefit for expanded newborn screening. We know that newborn screening allows for earlier diagnosis and treatment because it can avoid surgeries, treatments, misdiagnoses, and additional developmental and mental health costs. California, for example, has been shown to save $9.32 for every dollar that's spent on newborn screening. However, there's very little definitive data on how newborn screening can benefit the rare disease community. Although we have plenty of anecdotal evidence because of the complications in the healthcare system and sort of the data collection practices in place, it's pretty difficult to be able to put these pieces together to make that case. So this economic study would hopefully provide policy support, not just for the Foundation and for RDLA, but for all of you and all the advocates who are working to enhance newborn screening in their own states. So we need your help in order to make this happen. We urge both patient organizations and industry to look into joining our Community Congress program. The website is listed here. Industry can join at specific levels, so we urge them to contact us regarding that. For patient organizations, the program is free, and this allows you to have a roundtable of individuals who care about these issues, who can talk to each other and share ideas, and hopefully help us in crafting policy initiatives in the future. So visit everylifefoundation.org/community-congress to look into how you can get more involved. And with that, I'll open it up to any questions you may have for me regarding our newborn screening efforts.
This is Frank Burrows with the Abigail Alliance for Better Access to Developmental Drugs. I just want to make a quick comment, and that is I really admire you for this work. It's really fantastic.
Thank you very much, Frank. Definitely appreciate the support, and hope to work with you in the future.
We are always here. We'll be glad to work with you.
Hi, this is Mark Lenk with Shire, and I just want to add on to that and say that basically the California legislation would not have been done without Every Life Foundation, and you guys have done tremendous work on that and should be commended. You're true leaders in this. I just wanted to know if you have a timeline for the various projects you're undertaking, like when you expect the economic study to begin and finish, the webinar, and when you expect the state toolkit to be released.
This is Max. Thanks for the kind words, Mark. So for the economic study, we are still seeking funding to do it. I don't know if folks on the line have ever tried to put together a major economic study, but it's quite costly, so we're still looking for support to try to make that possible. So unfortunately, I don't have a timeline on that particular aspect. I think for the state toolkits, this will be something that we're going to discuss at the Community Congress meeting, the in-person meeting coming up in November. So that would be a great opportunity for folks to weigh in with the working group and see, are there parts in there that you want to see more information on? Are there other sections that we're missing? And I go through an outline of that because we'd like to get buy-in from the working group and make sure everyone is included in that process. So, that's happening in mid-November. That means we could have a draft of that, hopefully before the end of the year.
And the webinar?
We haven't set a date for the webinar yet, but I think we'd like to have the contents of the toolkit established. Think about when to hold the webinar. So again, we could be looking at late this year or possibly early in 2017 for that.
Okay, great, thank you.
Anyone else have any questions regarding the newborn screening program? Great. Well, you can feel free to contact me at the email address or phone number that are shown on the screen right now. And with that, I will move it on to my colleague, Max, who will give the Capitol Hill update and an update on the push for cures.
Thanks, Vicki. And thanks for everyone who's on the call today. As Vicki mentioned, I'm going to be talking a little bit about what's going on in D.C. and what could happen in the near future. Cures has already come up several times on the call, so I'm not going to belabor this slide, but for those who might not be familiar, this is a bill that's been in the works for over 2 years now, and it's really kind of a landmark piece of legislation that is critical for rare disease patients, but goes beyond just the rare disease community to lots of other communities in the sort of biomedical realm. So this is something that we see as incredibly important, and we want very much to get this done as soon as possible. And the end of the year is actually going to be our last opportunity to do this. Won't go through every single piece in here because we've actually heard about some of them today, but this gives you an idea of why this legislation is so important. You can see all of the various provisions that are in here. I've underlined open because this is a bill that the Every Life Foundation has been leading on, and nearly 170 patient organizations have signed on in support of that bill. And you can see there's a variety of other provisions in there that we would like to see signed into law. Again, this is a slide that gives you a little bit of a sense about the OPEN Act. I'm not going to, again, I won't go into too much detail on this, but basically the point and the key takeaway here is that we think that this bill could actually double the number of therapies available to rare disease patients. And I think everyone on the line has agreed that this is a huge area for us as a community, and it's an area of unmet need, and we think the Open Act could help in this regard. And I mentioned this earlier, but we've seen quite a lot of support from the rare disease community. In addition, we want to make sure that the priority review voucher program is continued and ideally made permanent. Paul mentioned this in his slide, but I think this is a good sort of reference slide because it explains a little bit of how the program works. And as Paul mentioned, the main takeaway is that this program under current law is slated to end at the end of the year in December. So this is why we're going to be pushing so hard to make sure that CURES is signed into law, to ensure that PRV continues, but also all of those critical provisions I mentioned earlier actually get signed into law so that we can start helping patients as soon as possible. So this slide goes into kind of the state of play, where we are around CURES. We still have some challenges that remain, and it's going to be a fight. We have seen controversy basically since the start of this process about how to pay for some of the proposed increases in the legislation. And some of the biggest items that have costs are around NIH funding, FDA funding, and the Open Act does have a cost as well, although it's relatively small compared to the other two items I mentioned. So Congress still has to figure out a way to pay for all of this, and we're hearing that there are discussions going on, although have not heard about any deals that have been reached. I think a lot of you have probably heard about what's going on at the White House. They're extremely interested in the Cancer Moonshot Initiative, and I think it's quite likely that we will see this included in the CURES legislation. This is quite smart politically because it, basically ensures that the White House will support, what Congress eventually comes out with and ideally passes. The other thing that makes this particular moment in time different than previous times when I've talked about this is that before Congress left to go into campaign mode, the leadership actually did pledge to make CURES a priority when they return from the election recess, and ideally make it a priority the week of November 14th. So that's what we'd like to see in terms of how this might work legislatively. There's been news articles published indicating that the version of CURES that was initially passed by the House in July 2015, we're likely to see what people are calling a slimmed-down version. Not exactly sure what that will mean yet, but some of the funding numbers that were achieved in the House-passed bill probably are not feasible at this time, so it'll be a smaller bill most likely. And then the House would pass something, and then it would go on to the Senate for consideration, and then ideally to the President's desk. But, there are still challenges that remain. There was an article that came out about a week and a half ago. Leader Pelosi was mentioning that there's not yet sort of unanimous support from the Democrats around CURES, so there's definitely still work to be done, and definitely a lot of work for people like us in the advocacy community to make sure that everyone is coming to the table to make a deal here and to make this possible. So what I'm asking of all of you is that we actually come together and in as much as possible unite in our advocacy. So we have very, very little legislative time left in the calendar this year. Congress comes back for just 1 week in November before they leave again for the Thanksgiving holiday. And then on top of that, we're looking at likely only about 2 weeks in December. So from now until the end of the year, there's only 3 weeks of legislative time left in the calendar. So extremely compressed time. And the other challenge here is that if we can't get this bill done this year, then we would have to start completely fresh in the next Congress. So all of the work that has been done by the committees and the advocates and everyone who's weighed in on this would be lost. So, what we're asking people to do is to really work together to make sure that CURES stays intact as a legislative package. package, and we think this is the best way to get all of the groups united, all of the groups together, and everyone pushing for the same thing. And that's what's ultimately going to yield us the highest likelihood of getting a bill done. So here's what we're doing. And there's lots of opportunities for folks to participate in these advocacy activities, and certainly would encourage you to do so because we need everyone's help right now. So we've launched an op-ed campaign. So we're looking at what we're calling key states, and they're key because those states are where congressional leadership are based. So we're looking at California, Kentucky, Massachusetts, and so, you know, these states are correlating to very influential members of Congress. So if you live in those states and are interested in doing an op-ed, please contact me. We already have a template queued up, so it's actually very little work to add in 1 to 2 paragraphs of a personal story, and then we can help get it submitted to your local paper. On top of that, we are in town in D.C. the week of November 14th, which is the week that Congress will be in session, and we will be going to Capitol Hill with advocates. I believe our founder, Dr. Cactus, will also join for some of those meetings. So we'll be there in person. I think many of you are aware of the photo campaign we have launched on social media, and many of you have already participated. We are still accepting photos for that. So if you have them, please send them our way, and when you take those photos, remember to post them on social media and tag your members of Congress in those posts. That way, you know, they'll see them and it will remind them what's at stake when it comes to 21st century cures. And then on top of that, we are looking at convening a National Day of Advocacy, and we're looking at Tuesday, November 15th. So stay tuned for more information on that. I can tell you we are likely to ask patients and patient organizations to lead a call alert where we'll be asking people to call Congress and to take some action on cures, and the exact details of that messaging will be determined as we get a little closer to the date, but I want you guys to mark that on your calendar because we'll need your help on that. So stay tuned for more on the day of action. Again, for folks who want to do something today, and there's lots of stuff that can be done, I mentioned the op-ed campaign, so if you want to get engaged in that, feel free to shoot me an email. And even if you're not in one of those key states, it's still an opportunity to raise awareness with your members about what's going on with cures, and certainly to raise awareness among the public in your state or your city. And then I mentioned that you guys can still submit photos, so please remember to do that, and again, you will hear more about the day of action. And then for those who are really savvy on Twitter or on Facebook even, here are some sample posts you can use when trying to kind of raise awareness and keep the momentum going. For some of these posts, you can also link back to our photo page because that's a way for folks in your network and your social media world to see that we're doing this photo campaign and ideally to participate in that as well. So lots of ways to get involved in the cures fight. And I also want to mention that this actually is not too far away, but Rare Disease Week 2017 is coming up next year. We're looking at the last week of February into early March for this. And one of the most popular things that we've done around this is offer travel stipends to patients. So this year we sent a lot of money out back into the patient community, and that $55,000 that went out, the stipends ranged from $300 to $1,000, and that's largely a function of how far patients are traveling to come join us in DC. And we do tend to give priority to folks who have never participated before and who have never been to DC. So the deadline is in December, but we always encourage people to apply as early as they are able to. That allows us some more time to plan and gives us a way to kind of gauge interest in the program. And so I'm sure many of you have seen our website for Rare Disease Week, but if you want to learn more, that's definitely the place to learn more about the program at the Rare Advocates website. So I'm going to wrap up there. Vicki is going to unmute the lines for us here, so if folks have questions about Rare Disease Week, about cures, about any of the provisions in there, I'd be happy to answer them. And we also have a chat function in WebEx if folks want to send in questions via text. Well, I'm not hearing any questions, so hopefully everything I said made sense, and hopefully you guys are in alignment with our strategy around this. But if, again, if people have questions or they want to discuss further, feel free to get in touch with me. So I will turn it back over to Biggie to close out the call.
Great. Thank you, Max. With that, I'd like to, if anyone has any questions about for any of the panelists today, you can shoot me an email at vganapathy@everylifefoundation.org or give us a call here at the office. I'd like to let you know that our next webinar and conference call, we've moved it back. It was originally scheduled for November 22nd, but we'll be hosting it on November 30th at 1 p.m. Eastern. If you have any ideas on agenda items, again, feel free to email them over to me. If there's something that you as a patient organization would like to share, if any industry folks would like to discuss any legislation, or if there's a legislative office that would like to present on our calls, we're always open. So feel free to shoot me an email, and I look forward to talking with you all then. Thank you very much, and have a good day.